Hello everyone, this is Shadi Reis from Detroit Medical Center. This is CVI 2023 in Austin. I'm really privileged today to be with Dr. Bianchi to talk about surgical management of FIMPOP. Christian, thanks for being with us.
A pleasure.
Yeah, so a lot of things evolving, and referral pattern is different, endovascular versus surgical. So can you give us an overview about the management of this disease?
Yeah, of course. Being a vascular surgeon, I think you have your three phases. You have your medical phase, you have your interventional phase, and you have your open surgery phase. And I think you are able to try to approach the patient's need based on your skill set. And we are lucky that we're training both on all three fields.
Yeah.
I think the most important thing continues to be selection of the patients itself. But you're absolutely right. The pattern has to shift. Endovascular is taking a more preponderance role without a doubt. Patients are getting sicker, are getting older, and conduit availability is less and less. So for those of us who do a lot of critical limb ischemia and limb preservation, definitely I think it is important to continue to push the endovascular envelope and adapt new techniques, including deep venous revascular arterialization, for example, as a good example of no option management of these patients to prevent amputations. Yeah.
So what is the optimum management at this point for somebody with FIMPOP disease, or POP disease?
Right. So I think, again, it depends on the PAD staging, right? For claudicators, I think we all advocate medical management and cardiovascular event protection or prevention. And then if that fails, then certainly stratify the anatomy of the patients and probably some sort of combination, depends on your philosophy, of endovascular approach first. If that fails, then a redo endo probably is a good approach for those patients with intermediate claudication. If you have a critical limb ischemia patient, I think it's a little bit different. If you have good conduit and an average risk patient, probably bypass surgery, as the best CLI suggests, maybe a good first option. Although we don't see that many of those patients. We have high-risk patients with poor conduits. So I think optimal management for those patients for limb preservation is endovascular approach.
So I'm interventionist talking to a surgeon. By doing endovascular therapy, are we totally eliminating the future option for this patient to have a bypass?
I think there is some controversy on that. There was some previous data from Basel that suggested that we're burning bridges, and the outcomes of bypass after endovascular intervention is somehow impaired. I don't subscribe to that. I think I think if you approach what segments and you have a good conduit, I think certainly you should do that in average risk patient first. But again, we don't have that many average risk patients, and we don't have that many patients with adequate conduits. So I think you are going to approach patients with endovascular approach first. And again, the modalities are there for you to choose from.
And it's enlightening to know from the surgeon to say that medical management so what is your protocol for medical management?
Absolutely. As you know, PAD is part of the atherosclerotic stress syndromes, and primary prevention, if the patients did not have cardiovascular events in the past or secondary preventions, we know that patients are not compliant to them, so always educate them and reinforce them. Antiplatelet therapy, lipid therapy, ACE inhibitors for the hypertension confer some survival advantages. I think that's kind of the foundational block. And then in terms of the claudication itself, manifested by, disability of walking, I think a medical exercise plus silastazole, it's a great first step. It takes time for them to work, but I think it's certainly worth because the natural history is very good. And when they fail, certainly interventional approaches.
Yeah. When do you see them back?
For claudication, usually when we start medicating, I see them back 3 months. That's average the amount of time that you need, and you want to check for side effects. Although obviously if they display early side effects, you want to see them earlier.
Well, thank you, Christian, for enlightening us on this important topic. Please watch these videos and others on CVI YouTube channel. This is Shadi Reis from CVI 2023 from Austin.